Dr. Mara Antonoff, thoracic surgeon and researcher from the University of Texas MD Anderson Cancer Center in Houston, to speak with us about operating in black box, lessons learned, technical accounts of operating in a heavily pre-treated field.
Thank you very much. I am a lot older than Dr. Pompili, and my vision is even worse than hers, so I also apologize. I need to get my laptop functional as well. I want to thank you all for the opportunity to speak on this topic. And I know everyone is getting tired and sleepy, so if you feel a need to stand up or jump around a little bit, please go ahead. And I'm going to speak at a record pace to try to get us through this as fast as possible. Let's see. Oh, thank you. I would prefer to give today's talk. No, thanks. Okay. Terrific. So in order to talk about operating in a heavily pretreated field, I think it's important for us to think a bit about what it's been like operating after neoadjuvant therapy in the past. So when we talk about operating after neoadjuvant therapy historically, it's important to recognize that years ago, neoadjuvant therapy was really recommended for a much smaller group of patients, and the number of agents, the options for agents were much more limited. Obviously, we have many more options now, but as we're thinking about what it means to operate in a heavily pretreated field in the modern era, we have to think about what it meant to operate in a pretreated field in the past era. So in terms of the surgical considerations, definitely we recognize that historically platinum doublet chemotherapy was the mainstay, and it's still used in many circumstances. But our data on surgical impact had traditionally been quite old, and we opted recently to really evaluate what it's like to operate after traditional chemotherapy, because we hear so many surgeons talking about their fears of what it's like to operate after novel agents, after immunotherapy, after targeted therapy. And if we're going to be fearful of that, we need to understand what it really means to operate after chemotherapy. So we looked very recently at surgical complexity after neoadjuvant treatment, recognizing that historically complexity is often approximated by blood loss and operative time, but I think that's not really the best way, because we know that in skilled hands, operative time and blood loss may still be quite minimal or normal, and it doesn't necessarily measure the complexity of the operation. We know the difficulty is often subjectively measured, and so we thought to explore the impact of nodal involvement and nodal response in a more recent era of cytotoxic chemotherapy. I have this notion in my mind that I believe that the extent of response to systemic therapy impacts the surgical complexity. And so I think for us as surgeons and as healthcare providers in general, to be concerned about the complexity of a case is maybe not the right thing. For us to recognize that if it's truly the extent of response to therapy that makes the operation harder, maybe we shouldn't mind that the operations are harder. Maybe we should just improve our skill sets and get a little bit better at doing complex cases, because at the end of the day, don't we want the patients to have the best response to the best drugs? I think we do. So if we look back, even in an era of historical systemic therapy, we looked at whether nodal extent of response impacted surgical complexity. And first, looking at patients who had more of a substantial reduction in nodal size or FDG avidity compared to those who did not, we saw that it was more frequent that the nodes would be unable to be removed from the pulmonary artery, and that the node would force a change in approach to vasculature. Moreover, if we look at those who got neoadjuvant treatment versus those who had upfront surgery, we found that those who had neoadjuvant therapy were more likely to need intrapericardial or proximal pulmonary arterial control, more likely to need reconstruction of the pulmonary artery. But again, I argue that this response to therapy, that patients are having such a great response to systemic therapy, whatever that drug may be, historically or in the future with any new agents we may not even have yet, don't we want patients to have a good response to therapy? I would say that we do. Even, again, if it makes our operations harder, then maybe we just need to get a little bit better. So looking at systemic therapy now, as we've been discussing all day, we have so many more options than we had in the past, and it's for many more patients. It's not just a narrow group of patients, and it's not just a narrow group of drugs. It's a much more, many more options, and we're going to see it in many more patients. Again, another argument for why we surgeons maybe just need to get a little bit better. So when we think about benefits and drawbacks of neoadjuvant trials, again, we may have these concerns that the operations are challenging, but there's so many advantages. It allows us to understand a patient's likelihood of responding in the future, and I know this is one of our greatest concerns. We just heard from Dr. Pompili how important it is to think about the patient's experience. They want to know what their likelihood is going to be to respond to these types of drugs in the future. It gives us evidence to clarify the mechanism of response. It may eventually enable prevention of unnecessary operations, but we'll be debating that tomorrow. It also may have a huge advantage over adjuvant trials, recognizing that adjuvant treatments can require much larger groups of patients over a much longer period of time to establish a survival benefit. The pathologic endpoints we get from neoadjuvant trials really allow us to evaluate these drugs in a much more rapid situation. So yes, the challenges are that these operations may be more challenging, and we're going to speak about that very shortly. And another issue is that I would argue we currently can't predict the pathologic findings, not even in the operating room, not based on our imaging and not in the operating room. So in terms of the impact on surgical outcomes, there have been these theoretical concerns for a missed opportunity for curative surgery, delays in surgical resection, and increased operative difficulty. I think the increased operative difficulty may be real compared to upfront surgery. I don't think it's real compared to historical systemic therapies. And these other issues, potential missed opportunity for curative surgery or delays in resection, will show with some data that that's not actually the case. We know that these neoadjuvant trials comparing chemo to chemo-IO all showed similar or greater rates of surgical resection in the chemo-IO groups, and I'll show the specific trials momentarily. What about the impact on surgical difficulty? It's less objective, and it's hard to measure in a clinical trial, but we saw in NeoStar, AEGEAN, Checkmate 816, and Keynote 671, in all of these situations that the operations may be potentially more challenging, there may be less minimally invasive surgery, but when you look at Checkmate 816, the conversion to open was less frequent after chemo-IO than chemo alone. Keynote 671, compared with chemo-IO had no impact on the choice of surgical procedure. So I think we need to make sure that we're not comparing apples to oranges. Is systemic therapy prior to surgery maybe more challenging than upfront surgery? Very likely it is. Is it more challenging when we have better drugs that work better? It doesn't even seem to be. It's just a heavily pretreated field. It's a heavily pretreated field regardless of what drug you get. And I think, again, it depends on how extensive the response is. I think if patients have a great response to therapy, it makes the operation maybe a little bit more challenging. But again, isn't that what we want for our patients, for them to have a great response to their therapy? What about oncologic and postoperative outcomes of surgery when patients receive these drugs? When we look at R0 resection, we saw similar or better rates after chemo-IO compared to chemo alone. We see this through several trials. In terms of surgical complications, we see similar or better rates after chemo-IO than chemo alone in Keynote 671 and Checkmate 816. So again, we shouldn't be comparing patients who are receiving novel therapeutic agents to patients who don't receive any drugs at all, but compared to our historical standards. And if we're seeing better outcomes for patients, better oncologic outcomes, I think a little bit trickier of an operation that maybe challenges us and makes us a better surgeon is in the end, the right thing for the patient. These are a lot of our treatment regimens that we have in the current era, and many of them involve giving therapy before surgery. And this is just something we're going to have to get used to as surgeons. When we look at radiographic response, surgical resection rate, and pathologic response rates, I want to point out the fact that the pathologic response rates are not the same as the radiographic response rates. And I think that's something we all need to be aware of. When we talk about the surgical complexity doesn't seem to predict the pathologic response. The imaging doesn't necessarily predict it. And this is certainly an area that we need to work on in the future. But one thing I want to point out here is look at how many of these patients underwent surgical resection. All these patients in these trials of novel therapeutic agents underwent surgery at a very high rate. So this fear that we're not going to be able to operate on patients, I think we need to let go of it. Looking at these trials shown here, Checkmate 816, Keynote 671, and AEGEAN, you see that patients underwent surgery at a greater rate than the control. They underwent minimally invasive approaches more frequently than the control patients who got chemotherapy alone, and R0 rates are the same or better in all of these trials. So again, these fears that we surgeons have about operating in patients after novel agents, we really need to get over it because patients are benefiting oncologically, and if the operations are harder, they're harder. So what about impact on operative conduct? I've shown here a couple of papers by Dr. Bott, by Dr. Sepeshi, who's here with us today, and we know that maybe these operations aren't the easiest. Dr. Bott reported on patients who received neoadjuvant nivolumab, and a third of these cases were started open, and over half of minimally invasive cases required conversion due to hilar inflammation and fibrosis. But I don't know that an open operation is the end of the world, and we're getting better and better at these operations. Dr. Sepeshi reported on our experience with NeoStar, and yes, we judge these operations 40% of the time to be more complex than usual, but what is usual in our current era? I think we really need to put it all in perspective. I want to go over a few cases to highlight some of the complexity of these operations, and I'm going to go through them relatively quickly, but hopefully emphasizing points that are relevant to you all. This first patient was actually one that I shared with Dr. Casconi. This is a 74-year-old gentleman who's a farmer. He had an ECOG performance status of 0. He had squamous cell carcinoma of the left upper lobe and had an FDG avid AP window node. So he was clinically staged as T1B-N2, and he was enrolled in NeoStar. He did have some baseline emphysema that could be seen on imaging and in his pulmonary function tests. And during induction, he developed pneumonitis as well as C. diff, and he was on this steroid taper. He had repeat PFTs that demonstrated a reduction in his pulmonary reserve, but his repeat imaging showed that the left upper lobe malignancy had near complete anatomic resolution with no FDG avidity of the tumor or nodes. So we really wanted to make sure we didn't rush into surgery in someone who was maybe not doing so well clinically for a variety of reasons. And you can see that the primary tumor showed no residual FDG uptake and near complete anatomic resolution. So what we decided to do was, after multidisciplinary discussion, which is always key to all of these cases, Dr. Cascone and I spoke, and we decided to delay surgery for a few weeks for further rehabilitation and then proceed with resection in this gentleman. And in the operating room, I found severe fibrosis and adhesions of the lung, and the hilar tissue and nodal basins were fibrotic, densely scarred, and all I could find intraoperatively was this thin linear scar in the left upper lobe at the site of the previous tumor, and it was very peripheral. So I made a decision at that point, because he'd had a reduction in his pulmonary reserve, and he seemed to be quite symptomatic from a respiratory standpoint, to perform a sublobar resection. Interestingly, though, pathologically, he actually had tumor nests in his air spaces and at the resection margin, and it actually looked quite aggressive pathologically. This was a bit of a surprise, and I point out this case only to highlight the fact that we aren't good at figuring this out in the operating room, not yet. We don't know which patients have had a great response and who haven't. He also still had involvement of his lymph nodes. And ultimately, this gentleman, unfortunately, he did develop recurrent disease a year later and ultimately passed related to COVID pneumonia during the pandemic. But I point out this case just to highlight that this was challenging. It seemed very reasonable to perform a sublobar resection, and he still seemed to have aggressive disease. But I don't think that's uniformly the case. We're just not good as surgeons at figuring this out in the operating room. In contrast, this was another patient on the same trial, a 70-year-old gentleman who had great functional status. He was a primary caretaker for his wife, who had other medical problems. He had an adenocarcinoma in the right upper lobe, and he had biopsy-proven right paratracheal nodal disease, and that was his only site of nodal metastases. He had reasonable PFTs to be able to tolerate resection, so he was clinically diagnosed as N2-3A disease, enrolled in the same trial. And during induction, he did fairly well, no major issues, and his repeat imaging demonstrated that the primary tumor in the right upper lobe was a little bit smaller, and he had showed decreased FDG uptake. And so he was taken to the operating room. This gentleman also had extensive hilar fibrosis, sclerotic lymph nodes, and he had a palpable mass in the right upper lobe. Complex lobectomy was performed. It wasn't easy, but that's why we train so hard, isn't it? And pathologically, interesting thing for this guy is that he had 98% fibrosis and inflammatory changes, only 1 to 2% viable tumor. So again, we're not super good at figuring this out in the operating room, and this patient is still doing well at current follow-up with no evidence of disease. I want to point out another case where I want to show you a little bit more visually what we see in the operating room after heavy pretreatment. This was a 59-year-old gentleman who had clinical T1B-N1 adenocarcinoma. He received chemoimmunotherapy and demonstrated a great response to therapy radiographically. And this is his case in the operating room. And I think what you can see is that the pleura is thickened, the tissues are fibrotic. You'll also note that this is a robotic operation. It's still being performed minimally invasively. We're getting better at doing these operations, even when it's really challenging. You can see that the tissue is thick. The planes are maybe not as clear as they would be in someone who didn't receive any systemic therapy. But again, I will point out, I think this is the case regardless of the type of therapy, and the extent of fibrosis is likely related to the extent of the patient's response to treatment. And this is one more case. This is a 74-year-old woman, T3N2 adenocarcinoma, who also received chemoimmunotherapy. And you'll see this was also done minimally invasively. Tissues are thickened. The operation is not easy, but it is being done, and is being done safely and successfully, and I think this is important to point out. This is even an interpericardial resection. It went fine for this patient. Dr. Spicer asked me to speak about heavily pretreated fields, so I do want to mention quickly about salvage resection. We know that since the Pacific trial, chemoradiation and IO may be offered to patients with stage 3 disease. You're all very familiar with the Pacific trial, 2-to-1 randomization of durvalumab after chemoradiation that was associated with an 11-month increase in progression-free survival. And I think, it's important to recognize that these are heavily pretreated fields that we may be operating on as well. The data are pretty limited at this point, and most of them are heterogeneous patient stages and checkpoint inhibitors, but ultimately I think it's important to recognize that we are operating on heavily pretreated fields in a number of different situations, and so we just need to be prepared for that. And again, if this means we need to optimize our surgical skill set, then so be it. I know that we are all here to discuss early stage disease, but I don't think Dr. Spicer thought he could bring me anywhere and put me on a podium without me talking about operating in stage 4 disease, so I will do it quickly. When we talk about heavy pretreatment, I think this is really where we see the most pretreatment. And so real quickly, I just want to mention that when we give neoadjuvant therapy in stage 4 disease, it's even more extensive, the changes we see in the operating room. So this was a patient who had a right upper lobe adenocarcinoma, stage 4 disease, and received neoadjuvant immunotherapy. This was on the Lone Star protocol, so she got ipilimumab and nivolumab, and then had non-progressive disease, was randomized to local consolidative therapy. And in the operating room, this patient had extensive adhesions, matted lymph nodes, hilar vessels that were indurated and fragile, and it was a really challenging case. It took a long time, but the pathology showed lung parenchyma with fibrosis, necrosis, and treatment effect without any residual viable tumor. So she obviously had a good outcome and is doing quite well at this time. This isn't only true for immunotherapy. This is a patient who had EGFR mutated disease and was placed on the North Star trial. This patient also had metastatic disease, received, according to the North Star schema, osimertinib, and had non-progressive disease, was then randomized to local consolidative therapy, and demonstrated a great response radiographically. The patient in the operating room had nodes that were fibrotic, scarred to the PA and to the bronchus, and had a pretty reasonable response, but still had residual disease. So again, we have so many situations where we need to get better and better at doing these difficult operations, where the nodes are fibrotic, where the hilum is scarred, and we just have to be better at finding the planes and getting the patients through it safely. And likewise, patients can receive other targeted therapies for ALK-mutated disease or ALK-rearranged disease. This is another patient, stage 4 disease on the Bright Star trial, who, according to the protocol with non-progressive disease, went on to local consolidative therapy. And again, severe fibrosis, nodes fibrotic and inseparable from branches of the PA, the pulmonary vein, and the bronchi. But these patients with great response, with no residual malignancy, may have no residual tumors. So if it makes the operation a little bit harder and helps us learn about the patient's disease, I think these lessons apply to patients of all stage disease. And if we've already learned this in stage 4, we need to be able to accept it for earlier stage disease as well. I know there's been a little bit of a whirlwind running through all of this, but I think, when we talk about operating after neoadjuvant therapy, we see these examples of fibrosis, adhesions, sclerotic lymph nodes, and this theoretical increased risk of bleeding and longer operative times, but we really aren't seeing increased complications or increased bleeding. There may be a greater risk for open surgery, but does it really matter? If I perform a thoracotomy that's the size of 4 of my fingers, is it really that big of a deal if the patient has an enhanced recovery protocol and they end up with EXPREL and they have no pain and they can go home on day 1 or day 2 regardless? We know that we may not be really good at predicting residual disease, but we're hopefully going to get better at it. Hopefully we'll have biomarkers coming soon. I do think we have to consider how far is too far, our allocation of resources, our equipment, our operating room access. But in summary, we've all seen in the last day that our multimodality options are rapidly expanding, that these pathologic endpoints are really pivotal in assessing efficacy, and they have a huge potential impact on the patient experience. And patient experience is the most important thing at the end of the day, is it not? So if it makes our operations a little bit tougher, perhaps we should be willing to do it. Our surgical cohort is evolving, and surgeons need to understand the implications for case complexity and the nuances for planning, informed consent, and resident training. And our multidisciplinary colleagues need to be right there alongside us as we try to understand these changes and how the operations need to be done. And the relevance to the patient experience is that this can impact their quality of life. It gives them the opportunity to have knowledge of their disease status. It can also preempt the development of resistance to whatever therapy they're on, help get them off some of these medications that may be helping them, but maybe they don't want to be on them forever. And it certainly impacts patients' social stressors in terms of their financial burden, the impact on their family, the time away from work, and their transportation needs. I apologize for going through so much so quickly, but I really appreciate the opportunity to present, and thank you for your time.